All right, for our ADL project, we have the ADL of eating and feeding with the diagnosis of autism spectrum disorder. So a little background about our case. We have a 3-year-old boy named Finn, who was diagnosed with autism spectrum disorder at 18 months. Finn has struggled with eating and feeding since birth and has been known to gag and vomit with new foods are presented around him, is very sensitive to smells, and needs TV or video to be playing at all meal times.
And then just a little bit about the diagnosis of autism spectrum disorder. So some common characteristics that can be present when diagnosed is having impairments in social communication as well as interaction, and then also having repetitive behaviors, interests, and also restrictive behaviors or activities. It is also a diagnosis that has no cure. And people who are diagnosed with ASD also have different ways of learning, moving, and maintaining attention to activities. And then related to this case with the ADL of eating and feeding, children with ASD commonly have diets that are self-restricted and have food selectivity. So disruptive behaviors can occur during mealtime, which the client in this case did when he did not have a video present while eating a meal, and having frequent meltdowns when new foods are introduced into diet or the environment, which then can cause gagging or vomiting, like Tyler said. And then just a brief overview on the occupation of eating and feeding as defined by the OTPF. So eating and swallowing are keeping and manipulating food or fluid in the mouth and swallowing it. And then feeding is setting up, arranging, and bringing food or fluid from the vessel to the mouth. And then just a little bit about the model that we chose, which is applied behavior frames. So the client in this case demonstrated inappropriate social behaviors with mealtime and feeding, such as, like I said, when a video was not present during his meal times, he would become very distressed and have negative behaviors. And what occupational therapists can use this frame with is behavioral reinforcement, skill instruction, and modeling. And I think that a really good example to understand this frame of reference is the Bandura's Bobo doll experiment, which showed that children learn by watching others, and that learning is increased with behaviors that are rewarded or reinforced. And then this frame of reference says that dysfunction is termed as maladaptive behavior. So specifically to this case, the client became easily distressed when not watching the video with a meal, like I said previously. And then continuing a desired behavior is done by the therapist when they are giving positive reinforcement to that client. And then here is the video of our demonstration of the intervention that we chose. Oh, hi, Tyler.
Hi.
So let's look at our visual schedule. So we just did bubbles. So can you take that one away? Good job. We just washed our hands. So what do we do with that? Good job. And now it is time to eat some yummy food. Okay. And after we're done eating, we're gonna wash our hands again. Okay, so what I have for you is some apple sticks, some chocolate, and your mom said you like both of those. Oh, nice. What's your apple sticks name?
John.
Oh, it's Esmeralda.
Oh.
Should we? Oh, how does it smell?
Smells good.
What's your favorite? Yeah, we can take a bite. Good job. What's your favorite color apple?
Oh, green.
Should we have our apples go up an escalator?
Yeah.
Ready? 1, 2, 3. Nice. Is it on the top floor?
We're gonna walk around.
Can you see the apple?
Yeah.
How does it smell?
Smells sweet. Now it's gonna go into another room.
Nice. Should we have our apples go down the escalator?
Yeah, he's done.
And they can meet our chocolate friend.
Should
Should we have them both go up the escalator or should we only bring chocolate?
Just chocolate.
Okay. How does that feel in your hand? Soft or squishy?
Feels a little hard. Maybe kind of crunchy.
Mhm.
Up the escalator.
How does this smell? Sweet or salty?
Chocolate.
Mm. We sniff it again.
I can smell chocolate.
Should we take a bite or have it go back down the escalator?
We can take a bite.
Nice job.
Yummy. Okay, we're done. We go back.
Oh, okay, let's go down. I have one more thing for us to try.
Okay.
We can have it be friends with chocolate. Is that okay right there?
I guess.
Should we look at what color it is?
Yeah.
What color is it?
Looks brown.
Mhm.
That's close to this color.
Does it look like it feels the same as the chocolate? Nice.
Yeah, it's pretty close. I
Nice.
suppose it can go up the escalator.
Is it soft or squishy?
Kind of soft. It's like the apple,
Mhm.
apple bar.
And it's the same shape as the apple bar too. Okay, should we have them go up the escalator together again?
Sure. Okay.
We can have them go halfway and then go back down.
Keep going.
Okay.
Building together.
What do they see?
Mountains.
What does it smell like when it's looking at the mountains?
Kind of smells like cookies.
Which is kind of like chocolate.
Kind of.
Good job.
That's good.
Oh, good.
I like that. Can I have another bite?
For sure. Yum.
Okay, I think they're done.
Oh, you're done?
Yeah.
Okay.
Yeah.
We have them go back down the
down.
escalator.
Yeah, we're gonna go home.
Okay, fuck. Okay, so really good job. I'm glad you explored that
Yeah, it was
food.
good.
So we're all done with this. So what do we do with that now? And now it is time to go wash our hands.
Okay, let's go wash our
Awesome.
hands.
So some of the evidence that we found related to our intervention and our frame of reference starts with Howe and Wang. They did a systematic review on the research on effectiveness of feeding interventions, and this was with children with that were aged birth to 5 years with feeding difficulties. 7 of the studies reviewed behavioral interventions, which included positive and negative reinforcement, shaping, physical guidance, discrimination fading, and escape extinction. The evidence was in level 1 to 3 between level 1 and level 3 articles, and they suggested behavioral interventions were effective for accepting a variety of foods, effective with mealtime behaviors, with weight gain, caloric intake, and self-feeding skills. Another article we found was Esposito et al., and their study was aimed at giving a guideline for treating children with ASD and food selectivity. They also found there needs to be assessments that are either directly or indirectly given that will lead to an intervention that is effective. Some of the assessments and interventions they found to be effective are listed here. And the behavioral interventions need to be highly structured, and they have to have manipulation procedures to then decrease how often the problem behaviors occur. And then our last article we found was Peterson et al., which looked at ABA interventions and that they worked in association with children who have ASD and food selectivity. 6 of the children, all that had food selectivity and ASD, were randomly assigned into either ABA or control groups. Children were aged 3 to 10 and consumed 3 to 20 different foods. The caregiver of these children selected 16 non-preferred foods and then separated into 4 food groups. The new foods were introduced in the second section. The ABA group Hand over hand guidance was used with utensils in combination with instructions and praise. The children were evaluated how much they accepted a new food and how much they ate of it. The results were that the ABA intervention group had a higher level acceptance of new food, as well as ate more compared to the control group.
And then just some clinical reasoning questions to think about before Friday are, what are some safety precautions to have in mind for the client and anyone near him during feeding or eating? And then what are some sensory challenges that can occur with food selectivity? And lastly, what are some occupational therapy strategies you can think of to make eating new foods more engaging or fun? And then here are references.